Thank you. Welcome, everybody. We are really excited to be joining you for this incredible virtual conference put on by North Star Reach and Serious Fun Camps. I'm Melissa Cousino. I'm a pediatric psychologist at Michigan Medicine. I work with our pediatric heart and kidney transplant programs, and I've been working with our groups there for the past 5 years. So clinically, I'm a pediatric psychologist that specializes in working with transplant patients. I'm also newly the director of psychosocial services for our congenital heart center. So in addition to working with transplant families over the past year, have really grown my work with cardiology families as well. And as Dr. Fredericks and I will be sharing, we have a growing program of research related to psychosocial outcomes in our transplant patients and their families. And so we're excited to be here today. I'll let Dr. Fredericks introduce herself.
Hi, welcome everybody. I'm Emily Fredericks. I'm the Director of Pediatric Psychology at Mott Children's Hospital, and I've been part of the Transplant Center for, I can't believe to say it, 17 years. It came in 2003, and I work with the liver transplant program primarily. And I remember when camp was Camp Mishitanki with a lot of the Doug Armstrong and Vicki Sheik. I've been involved with the program for a really long time, and as Dr. Cousino mentioned, clinically, we work with families from the pre-transplant, post-transplant time period. Our research really models that, focusing on ways to help families with coping, taking medications, and preparing for the transition from pediatric care to adult-centered care. So that's some of what we will talk about today. We do have some slides presented, but please make use of the chat. Mike will be monitoring that for us, but we'll also be looking at it. We really would like this to be interactive. If you came into this session really hoping to get answers to something or want us to touch on something, please drop it in the chat, and we'll be happy to follow up on that for you.
All right, we have no financial disclosures. We are both on Twitter, and we'd love for you to join us there. We share a lot of information about transplant research and resources, as well as cardiology resources. So we will see you in the Twitter world, this whole new virtual world we're all living in. We want to also acknowledge and thank the organizations that have funded our research and our work over the years, particularly NIH, International Society for Heart and Lung Transplant, Enduring Hearts, and the Transplant Center, which has been at Michigan Medicine, which has been incredibly supportive of the pediatric psychosocial research that we do. As Dr. Fredericks was mentioning, we have a number of slides today, but given that this is a breakout, we're really hoping that this can be more interactive, and we want to focus on kind of your most pressing questions, your most biggest challenges and concerns. So we're going to start by kind of walking through pre-transplant and post-transplant considerations. And we have a number of slides on helping your child and family cope. We have some slides on back to school and as it relates to COVID and considerations for transplant and cardiology families. And we are here to talk about transition to adult care, adherence. So again, please speak up, tell us a little bit about yourselves or what you're interested in, and we will certainly make sure that we're focusing most of our time there. So to start, I think that the process of transplant or heart disease certainly looks like this for a lot of families. The waiting period, the news that your child may need to go on the transplant list, the surgery itself, the post-transplant care, news of rejection or PTLD, the challenges that you face, retransplantation for some. And so, families often talk about it as this roller coaster with ups and downs and twists and turns. And so we are planning to kind of walk through some of these various phases of this roller coaster. But as a starting point today, this is one thing I say multiple times per week to patients and families, is that most often one is not responding abnormally, but rather very normally to abnormal life experiences. And so, when talking with kids, with young adults, with families, the sadness, the worry, the anger, the frustration, all of those feelings one may feel are really normal responses to the really abnormal things that one faces when facing a chronic illness or life with a transplant. And so I always like to start there, and that, that is why at the University of Michigan, we have psychologists integrated in the transplant process from the very beginning, because we think it is quite normal to have these experiences throughout the course, and we really want to be there to support our patients and families through that. So what do we know about pre-transplant? I know we may also have some cardiology families joining us too, and so we'll certainly can talk about that, but I also know that Dr. Strohawker just spent some time doing that in one of the breakouts as well. So we'll focus in on transplant for a bit, but please continue to ask questions if you have questions kind of specific to cardiology. So there's been some research on mental health in the pre-transplant phase, but the data is limited by a small population and various transplant types. So often these studies are done combining kind of all of the organ groups across all ages, transplants, and in infancy to adolescence. And we know that many factors can impact pre-transplant emotional and behavioral health. So, physical health plays a part, disease severity and illness, pre-transplant, the age of the child, the functioning of the family during the pre-transplant phase, whether they had baseline mental health challenges pre-transplant. And, a challenge that we face as psychologists working in transplant is symptoms of mental health challenges very much overlap with symptom of advanced organ disease. So, when children and young adults are not feeling well, they are more likely to be fatigued. They may have changes in their appetite. They may have changes in their sleep. They might be sleeping more restless, needing more naps. They may not want to do as many favorite or fun activities. And so it can be hard at times to kind of parse out, chronic illness versus mental health challenges. And so it's something that we're kind of always taking into consideration, when we're working with families. In terms of what we do know, so in the heart population during the pre-transplant phase, about 20% to a quarter of our pediatric patients have clinically significant levels of depression, anxiety, or adjustment-related disorders. And in the kidney group, particularly because of the stressors of dialysis, we do see higher rates, upwards of 50% of clinically significant depression, anxiety, or adjustment reactions. Certainly dialysis is an additional considerable stressor on families during the pre-transplant phase. And what are some of the things that drive this? What are some of the things we hear from our patients and families? So certainly, something that comes up in our kids a lot is this idea of social isolation. So their peers are not having these same experiences. They may not be able to go to school or may not be able to play sports. So many times my patients on dialysis talk about not being able to swim. So, this very normal childhood experience that during the pre-transplant phase or dialysis phase, they're unable to do. And so social isolation can drive some of those symptoms of mental health challenges that we see. Restrictions are very common in the pre-transplant phase, whether it's fluid restrictions or diet restrictions, activity restrictions, not being able to do a preferred sport, or as I was talking about, swimming. So again, that can drive some of this increased sad mood or increased worry. Certainly changes in family and parent functioning understandably occur during the pre-transplant phase. Parents and caregivers may have changes in their jobs and their caregiving role demands. One is balancing the siblings while the other is there in the hospital with the patient who's waiting for transplant, and that impacts the child. The wait for transplant is hugely unpredictable, and that in and of itself is a stressor, not knowing, if you'll be in the hospital for a holiday or a birthday. This loss of control, independence, and privacy is another thing that we know is a risk factor for our kids particularly our adolescents. In the hospital, so many patients tell me this room becomes my bedroom, my bathroom, my kitchen, my living room, and all of you are in it at all times whenever you want. And so, this can be a thing that we think about. And then pokes, surgeries, medications, these are burdens, of course, that can certainly increase anxiety and cause distress for our young patients, but throughout all age groups in the pre-transplant phase. So I know that some of the talks today and yesterday have also talked about parent and family functioning, and Dr. Colburn specifically talked about, parents and coping with your child's illness. In terms of our organ transplant population, we know that in the pre-transplant phase, there's higher rates of parental stress when compared to healthy control groups, a very normal response to the abnormal. But particular stressors that parents report are financial stressors and disruptions to the family system, and then changes in relationships. So, the best friend, the family members, your relationships may be different based upon what you're experiencing, and that can be a stressor. We also know that there's higher rates of PTSD symptoms, even when compared to other childhood illness groups, including sickle cell disease and HIV. And both mothers and fathers, although there's much more limited research on fathers, report very high distress in the pre-transplant phase, but they have different ways of coping. Mothers being much more active in terms of their coping, and fathers being a bit more guarded and kind of withheld in their coping, but both acknowledging that the pre-transplant phase is very stressful. Things that parents report or caregivers report as major stressors during the pre-transplant phase is just a lot of parental guilt. The guilt of separating time between other kids and the child that's maybe in the hospital or the one that's coming for appointments. The severity of the illness versus their transplant status. So parents will talk to me about, I don't want them to get sicker, but we want to be higher on the transplant list. We want to get that organ quicker. And so, just that balancing of what one is hoping for or wishing for is something parents talk with us about. As we've talked about, and it's a theme across, is just this changes in family and parent functioning and kind of dynamics and caregiver burden. Again, for parents, the weight and the unpredictability of transplant as a stressor, also the loss of control, independence, and privacy for parents, a stressor. I have one parent, and this metaphor has always stuck with me, but she said, it's like your kid gets put in a car and there's all these people that are kind of telling you where to go, and they're pointing different directions. And sometimes you don't even feel like you're invited to ride along, and you have no idea where they're taking your kid. And she said, I don't need to drive the car, but I at least want to be the very opinionated backseat driver. And that metaphor has just always stuck with me, but this idea, when there's many teams involved and, they're constantly talking with you about these things, can be a big stressor. And then, as we've talked about, financial stressors, job-related stressors, relocation for some families who need to be within 4 hours or closer to the transplant center to be listed. So in terms of siblings, there has been very, very, very few studies, but something that we certainly want to be paying attention to, that our siblings are also impacted during the pre-transplant phase, with about 25% showing kind of clinically significant emotional and behavioral problems. And so, as transplant psychologists, we're very committed to our transplant patients themselves, but we certainly think of the family system and how we can support siblings in addition. Okay, so Dr. Fredericks is going to talk a bit more about the post-transplant phase, and then we'll pause and see what questions you have, and then we have a number of slides kind of, so what do we do? How do we help if our child, if our caregivers, our siblings are having some of these challenges that we've discussed?
Thanks, Melissa. I don't have control of this. Thank you. So very similar, I work predominantly with families who are on the post-transplant side of the process. And just as Dr. Cousino was saying that, 20 to 25% or upwards to 50% of children on the pre-transplant side are experiencing significant mental health concerns. We also see this on the post-transplant side. At any given time, about 20% of all youth, whether it's transplant or not, just general population, will experience what we call lifetime incidence of a mental health issue. And so that is, again, normal response to abnormal. We expect all kids to have some struggles here and there. When we're talking about significant depression or anxiety or behavioral problems, this is when it starts to be, having trouble more days than not. It's not just a couple of bad days here and there. It's when we start to see pervasive problems that are interfering with functioning, interfering with ability to be with friends or go to school. And we see that with our post-transplant families, these children, we have about 20 to 50% of children who have clinically significant symptoms of depression, anxiety, behavioral and adjustment problems. And this is all pre-COVID data. We are seeing that I think that some of the percentages are going up, at least right now. If we were going to do a survey of mental health concerns today at any given time, I think we would see a lot of symptoms of depression and anxiety, particularly among our adolescents who are doing distance learning. And again, we can talk about this later as the impact of COVID on top of dealing with chronic illness and transplant. So as Dr. Colgren may have mentioned earlier today, but we see this within our transplant families, 15 to 30% of children and adolescents who had a solid organ transplant experience some post-traumatic stress symptoms. And these symptoms of depression, anxiety, sometimes they look different in kids than they do in adults. It may not be depression where your teenager or young child is crying all the time and looking sad. Sometimes this comes across as being really irritable and low frustration tolerance and angry. And so sometimes we see families presenting to us with concerns about behavior when we start to see them in therapy. Sometimes it's more a manifestation of depression. So all of these things, when we talk about emotional and behavioral health and we ask these questions, this is one of the things I like to tell our patients and our families is I'm not asking these questions to be nosy. I'm not trying to kind of get into personal business, but we also know that the long-term health outcomes can be affected by mental health and emotional health too. So having a psychologist and social workers embedded on these teams, we really are taking a team approach to physical health, mental health, and emotional well-being. And I like the example that Dr. Cousino just gave about parents being the backseat drivers. In our clinic, we present a model of the entire team, and the child and the parent are most definitely part of our teams. And as we talk about the care of your child, both physically and from emotional and behavioral health standpoint, we most definitely include parents as part of that team. And I'll talk about this when we get into the transition part. A lot of parents become concerned, rightfully so, that they are going to be pushed out of the car, so to speak. And that's definitely not the case. We want parents to be involved as much as possible. We can go to the next slide. So the reason also that we're concerned about emotional and behavioral health is because of the impact it has on adherence and health outcomes. Children and adolescents who experience mental health concerns are at risk for poor health outcomes. So if we have a child who has a chronic health condition and a behavioral and mental health condition, the stakes are higher. If we're talking about children who have had a transplant, again, we are very concerned about adherence. And sometimes when we think about adherence, it can become overly simplified. I know I have many parents who will say, I don't know why this is so hard. He has to take a pill in the morning and a pill at night. This is not so hard. But it can be really hard. I know that for some, that it is a good thing that kids and teenagers who have had transplants feel just the same as their peers. They don't feel sick, and that's a good thing. We want them to have the sense of normalcy. So they may not have a cue to take this medication. Some chronic illnesses that if you miss your medication, you're going to know it pretty quickly. So if you have type 1 diabetes and you forget to take your insulin, you're going to feel the effects of rising blood sugars pretty quickly. But if you're taking immunosuppressant medications and you miss a dose, you might not feel an effect ever, or it might be further down the line detectable on a lab value. So this can be somewhat challenging in trying to help adolescents in particular take their medications. So we do know that non-adherence to medication is very common, 50 to 70%. And part of this is because we have pretty strict rules about it. We really would like adherence to medication to be about 100%, because we don't know, the research isn't there yet to know what the wiggle room is. We don't really know as well, as long as you take your medications about 85% of the time, you should be able to prevent rejection, because it is individualized for each patient, each underlying disease type. So I also want to just kind of take a step back and talk about what we mean by non-adherence. And this is one of my pet peeves. I don't like when people refer to it as non-compliance, or you're not obeying, or you're not following the rules, because that also sets up this hierarchy that patients and parents should do what we say, and you should obey these rules, when really adherence is this partnership between these are the recommendations that we make to maintain health. And so in this situation, it's in order to maintain the health of your organ, you have to take these immunosuppression medications twice a day. And most of the time, parents and the patients will be like, yeah, I agree that that's a good idea. I want to keep my organ healthy. I agree that this is important. So once they agree that, yes, this is important, there are lots of other barriers that can get in the way. We know that non-adherence to medication is 4 times higher in teens than in adults and in young children, for a variety of reasons. I think 10-year-olds are really good at taking their medications. They're pretty good rule followers. They'll call you out if you forget to give them their medications. 16-year-olds, they have their own lives. They get busy, and so sometimes they honestly just forget to take their medications. So the risk factors for non-adherence are older child age, again, the adolescent age range, poor mental health functioning. Sometimes that is when you are depressed, it is hard to be motivated to kind of do anything. Also, some of these conditions, depression, ADHD, you have increased forgetfulness. So we know that this is associated with mental health, with poor adherence. Sometimes families and adolescents and children will report that symptoms of post-traumatic stress impacts their adherence, because every time that they are taking medication or going to get a lab draw, they are reminded of things that are traumatizing to them. So that can also be an avoidance strategy. Executive functioning and limited medication knowledge. So we run into this a lot, and I thought I was taking my medications correctly, and when we start asking about, well, what do you take in the morning and what do you take at night, it becomes very clear that it was a miscommunication. They thought they were supposed to take 10 milligrams, and really a nurse had called and increased it to 20 milligrams. So sometimes it's a miscommunication about truly not understanding what you're supposed to be taking. So I call that non-intentional non-adherence, that it's not something that someone is doing, they're intentionally missing their medications. It's just a gap in knowledge. The same thing when we talk about executive functioning. Executive functioning is our ability to plan, to organize, and to think ahead. So you can think about adolescents. Again, this is my prime population that I work with. If you're planning, if you have a sport after school, think back in the day when we used to go to school and have activities after school. You had to plan ahead to know, like, I'm leaving at 7 in the morning and I might not be home until 10 o'clock at night, whether going to a sport or a job. What do I need to take my medications with me. So that takes planning and ahead of time. So executive function, the ability to plan, impacts our ability to take medications on time. We also know greater family conflict, lack of family routines or regimens can also affect adherence. If things are somewhat chaotic and stressful in the household, it's very difficult to maintain filling up a pill box or remembering, did you give our child our medication or did you, or who's responsible for these? So again, when things are not predictable or stressful, then that can lead to changes in adherence patterns. The crossroads between childhood and adulthood. This is where I spend a lot of my career, is talking about the transition from pediatric to adult-centered care. Again, I like working with adolescents, the 16 to 23-year-old group. Not a lot of people don't usually go into pediatrics because they want to work with 20-year-olds, and a lot of people don't go into adult medicine because they want to work with 20-year-olds. But I really like working with this population. And over the last 10 years, there really has been an increase in attention of trying to help our solid organ transplant recipients successfully move from pediatric care to adult care. And this is a great sign because organs are lasting longer, we're having better health outcomes. And so when we talk about having a transplant in a 2-year-old, for example, with liver transplant, we really are playing the long game here. We are talking about like having a transplant to have a long, productive life and a quality of life. So with that, we talk about transition and care. At University of Michigan, we have transition programs. We're very intentional about trying to build skills, and we start this around age 11 or 12, and it's a very gradual process. So when we're talking about transition, we're not just talking about moving from one clinic to another clinic or one set of doctors to another set of doctors. We're also talking about the transition of responsibility from a parent-managed condition to an adolescent and young adult managed condition. And that shouldn't happen all at once. It should be gradual. So we start very early with helping our preteens, so the 11 to 13-year-olds, and some of them think, oh, I've got this all handled, I'm doing this all on my own. And we actually pull parents back in, like, well, because we're predicting that the drop-off. You can have a 12-year-old who has perfect adherence, and then a few years later, when they hit adolescence, we see a dip in that, and that's a totally expected response. So we start focusing on self-management skills, so health-related knowledge. Can you tell your transplant story? Do you know why you had a transplant? Do you know what medications you take? And then we build on that as the child gets older. Do you know what kind of health insurance you have? Do you know how to fill a prescription? We often joke in clinic, again, being at the University of Michigan, one of the top universities, we have college students across the way, and a lot of our teenagers are very impressed that they, or young children even, know what a copay is or what their insurance coverage is. And many of the college students across the street have no idea. If you were to stop an average 20-year-old and say, what's your health insurance and do you know what a copay is? I don't know, whatever my parents tell me that it is. So we're trying to increase these skills so that our young adults, by the time they get to the adult clinic, can be independent. One of the key things that we talk about in the transition process is increasing independence. With that comes increasing communication skills, decision-making skills, being able to communicate with your medical provider. We spend some time alone with the adolescents so they can practice having conversations with their medical team, giving them opportunity to engage in conversations around privacy and confidentiality. But at no point do we ever say, we're going to remove the parent from this completely. Instead, we talk about the parent's transition from being the primary keeper of all medical knowledge and medical regimens to becoming someone who's sharing these responsibilities with their teenager. And then the parent becomes the consultant. So the adolescent young adult is taking the primary role, but the parent and caregiver, they're there as the safety net. We never want to say the parents are completely out of the picture. Just as if we had a 25-year-old present on the adult side by themselves needing to have a transplant evaluation, we would most definitely ask them, who are your support people? No one should be doing this completely independently. So we say the same thing for our adolescents and young adults. Oftentimes the teenagers and young adults are like, I'm fine, just tell me where to go on the adult side, point me in the right direction. And the parents have the harder time with that transition to a new team. But this is why it's important to talk about transition as a process rather than just this event of moving to the next clinic. So if you want to go to the next slide, there we go. So again, across, as Dr. Cousino has already talked about, and if you went to the keynote this morning, Dr. Colgren may have spoken about this as well. We know that parents also are stressed. And again, this data is all pre-COVID. We know there's a whole nother layer of parent stress going on in our communities right now. Parents experience a higher rate of PTSD, especially if transplant was unexpected. If your child was otherwise healthy and then ended up at your pediatrician's office, and then you find yourself at the hospital having conversations about having to have a transplant. That there are a lot of the PTSD symptoms associated with that can lead to kind of either missing appointments or higher anxiety and seeking out more appointments and more reassurance. So that is our job as a team to help support parents just as much as we are supporting the child and adolescents. We have see that, again, parent functioning affects child functioning. I'm sure you've all heard the adage when you're flying on an airplane, again, back when we used to travel on airplanes, the advice to fix your oxygen mask before you fix somebody else's. You have to take care of yourself before you can take care of somebody else. And so when we're dealing with our children and our adolescents in the transplant communities, we also have to help take care of our parents, and recognizing that we're giving a lot of instructions, expecting a lot. You have to get labs drawn at certain times, you have to come to clinic visits at certain times, while also fitting in the care of other siblings in the home, maintaining your jobs. So we recognize that it is a lot of stress, and it really is a family dynamic that is important for all of us to help support. So with that, we'll pause if there are any questions or anything that you want us to attend to. Otherwise, we can continue going into some more kind of tips and coping with mental health and behavioral health. All right, I'll hand it back over to you, Melissa, if you want to go.
Sure. All right, so please speak up or send us a chat if there's an area that we've talked about that you want to spend more time. But hopefully some of these things we discussed are kind of relevant across the entire disease course, whether it's transplant or cardiology. So actually, Dr. Fredericks, nice segue. As we were just saying, you know, we think it's really important for parents, caregivers, and grown-ups to first prepare themselves. And so, you know, that we actually have this image here of this idea of, you know, putting your mask on. It's really hard. As a parent, I don't know that I would follow that rule myself, but I understand, you know, why we're asking that. We certainly know that child anxiety and mood is directly associated to parental anxiety and mood. And so I often will quote this study to parents, particularly as it relates to procedures. And so this is an older study, but they found that when a child was getting a poke or going in for a surgery, more than half of the child's response was directly associated to how their parent was responding about the procedure. And so, you know, I will often talk with parents about really making sure that we're making that space to help address their own kind of self-care needs, and that getting help for yourself or taking that time for yourself is caring for your child. It is not at all being selfish. It is actually critical to your child's emotional and physical health. You know, I think it's also important to know kind of what is normal in terms of a child's response to chronic illness stressors. And so certainly in toddlerhood, you know, what would be a normal response to chronic illness or transplant or a new diagnosis would be increased fear of kind of separating from grown-ups in their lives. We may see regressions developmentally. So certainly a child that was toilet trained, for example, or sleeping in their own bed, it would not be uncommon or abnormal for them to have regressions in those areas. They may be more difficult for them to sit still. Some young kids conceptualize illness as a punishment and kind of wonder why this happened to me. What did I do wrong for this to happen to me? They're very concrete in their thinking. So with my transplant patients, one of the most common questions I get in my younger kids is, well, will I get a boy's heart or a girl's heart? I mean, they're very, very concrete in kind of thinking about these things. And so, you know, we help them to understand in a way that they don't have the ability to think abstractly. And then, as we talked about kind of in terms of parental mental health, they're going to really look to others for how they should respond. And so, you know, I think that when we're talking about getting pokes, you know, with this idea that this is to keep you safe, this is to check your med levels, you know, really reinforcing that this is very important, as opposed to I don't like pokes either, because that reinforces for them that this is a scary thing. I saw a chat just popped in. I'll keep moving along, and once we kind of get through this section, we'll look at the chat. In childhood, so kind of school age years, magical thinking is very common. So this idea that something might just be fixed, or kind of, again, struggling to kind of understand the abstract nature of illness. But they begin to understand their bodies a bit more. So in this phase, I think one of the most common things we hear or fears that kids have is this idea of the surgery itself. lots of questions about being cut open. What will the scars look like? What will they do? How will they, I have kids ask me about breaking their bones. And so they're really focused on their body and how it works and how their illness may impact that. They're likely to have lots of questions, but if we answer kind of honestly and in a developmentally appropriate way, they're usually quite pleased with the response and can move on and shift into another area. Are really looking to develop mastery. So this is a great age to offer choices, so if they are going in for a poke, which arm do you want it? And what color band do you want? And trying to give as much kind of control when a situation feels very out of control. And adolescence, which we've spent some time talking about, this loss of autonomy is in privacy. The importance of social relationships is huge. And so let's see, I want to just make sure we're paying attention to the chat.
Dr. Cousino, if I can go back to the adolescent slide,
yeah,
because I think that might relate to the question. The question that came through is there a higher incidence of youth stopping their medications among children who have lifelong chronic illness as opposed to children with solid organ transplants from sudden illness? I think that if I'm understanding your question correctly, and I think that there hasn't been really good research looking at adherence rates among children and adolescents with solid organ transplant and other chronic illness groups. But what we do see in the limited amount of research and what we see clinically is that, yes, sometimes duration of illness is a risk factor for non-adherence because of burnout, and especially as it goes through the developmental period. So if someone is diagnosed with a chronic illness as a young child, and this has been the parent-managed illness, and then it is handed over to the adolescents, and you fit into this adolescent stage, that adolescents definitely want to be normal. And this happens with the young children too. There's a high disease burden. They feel that they're just tired of it, or it's not fair that they have to do this and no one else has to do this. So absolutely, it is very common for children and adolescents to want to feel normal and to just take a break from taking their medications. A lot of times with our adolescents in particular, it's developmentally appropriate and expected for them to feel that they are being evaluated by other people. So they perceive that others are paying more attention to some of the things they don't like about themselves than others might. So sometimes they have an intense need for privacy. They don't want to talk about transplant, or they don't want to talk about their scars or taking medication around their friends. So it becomes something that they try to hide in an attempt to be normal. So it is the difference sometimes that we see with adolescents who are transplanted as adolescents or as a result of a sudden illness, that we see that their adherence may be higher because they don't know what caused the reason for transplant. So sometimes that's scarier, and if anxiety is maintaining some of that adherence a little bit more, or they were transplanted as an adolescent and they were participating more in the conversation, so they have a different set of knowledge as opposed to someone who's been dealing with this all through childhood and never really felt part of the conversations. So I think that is a really good question. And absolutely, if the question is it common to want to feel normal for a while? 100%. Sometimes with our interventions, we do try to take breaks and say, okay, mom and dad are going to take over all of this management for you, and they're going to be your alarm clocks and remind things so you can kind of have a mental break for that. But it is most common, definitely common for them to want to feel normal. Did that answer your question, Shelley?
It did. And can I ask just another follow-up question to that? So, and to get back to the parents, like when you were saying, how can you forget your medicine? It's once in the morning and once in the evening. You have a youth who wants to feel normal and have some control, and they granted don't do it in a really smart way, but they're an adolescent. Is there a recommendation for, say, counseling, because you've got yelling at them even more about not taking their meds isn't good, but you obviously have a concern, like what happens if there's rejection, or if there's a reason why we have to get another heart, and you're going to lose that chance, and there's this fear. So you have a different type of fear on the parent side versus you're not listening to me on the adolescent side. So is it realistic to say maybe you should seek counseling at that point, if it's going over the rocky edge?
Well, well, I'm going to be biased and say that you don't need to wait till things go over the rocky edge to get counseling or to elicit support from the transplant team. Social work, nurse, psychologist. There are so many apps now available to help with adherence. But if you feel that discussions around medication taking are becoming contentious, or you're feeling like you're walking on eggshells when you're like, I want him to take his meds, but if I ask, it's going to lead to a huge fight, then most definitely reach out. Sometimes we have these just kind of brief 15-minute interactions with families in clinic, and now with video visits, we do this a lot more easily because families don't have to drive 3 hours to clinic to come to see us, and we can offer some individualized tips. A lot of this fits into what we do for transition planning, and we assess what the adolescent's knowledge is about the reasons why they take their medications. While we also know that knowledge is necessary, but it's insufficient in changing behaviors, and sometimes we're able to partner with the adolescent to kind of see what would be motivating, what kind of goals do they want to reach. I just saw an adolescent a few weeks ago who didn't realize that she would be eligible for another organ at some time in her future. She thought, well, this is the one I have. This is the only one I'm ever going to get. So it doesn't really matter if I change my behavior. And once we had those conversations around, no, most definitely, you could be eligible for another transplant if you were to need it as a young adult. A light bulb went off. She didn't really realize that. So sometimes it's having a conversation with someone who is not your parent can really go a long way.
Often too, what we do know from just the general chronic illness literature is that adolescents and young adults want independence in their chronic illness management, but they also don't want to be alone in their chronic illness management. And so it's really hard to strike that balance as a parent or caregiver and grown up. They don't want to feel like they're doing this all on their own, but yet they also don't want all of the reminders and bugging from their parents. And so what we'll often set up is this like system that kind of everyone can agree to or feel comfortable, and that the adolescent or young adult, they will manage their meds. They will fill the pill box, parents will check it, or grown-ups will check it later and make sure it was done correctly and let them know if they did it right or wrong. They will set their own alarms or their Alexa or their Med app or whatever it is that they're using, and then within an hour, or 30 minutes, we'll set something up kind of based upon their meds or what the expectation is. If they haven't told their parents, usually by text, like took my meds, then parent or grown up or caregiver can then check in. And so that tends to be like a compromise that will strike, that like you're going to get a window of independence, an hour, a half an hour of independence. But because we don't want you to be alone in doing this, and because this is really hard, we're going to check in. And it's hard for both, it can be hard for parents to like really stay quiet for that hour or so to say, did you take your meds? Did you take your meds? Did you take your meds? But that usually tends to be a compromise that we strike. And also, Shelley, I really liked how you wrote, like, we don't understand how they miss their meds, but we also don't understand what it's like to have a chronic illness. And that's something I hear from a lot of my patients. I think parents, you are absolutely in this with them, and you are absolutely experiencing this with them. But sometimes it can be really upsetting to kids when we're too in it with them. Like, no, you don't know what it's like. I'm sure that's what we hear with our adolescents. And so what I will say to patients, and what I encourage parents to sometimes say is, no, you're right. I don't know what it's like to be 17 and have a transplant. I don't know what it's like to have a new diagnosis of cardiomyopathy, but I do care what it's like for you. And so can you help me understand? And as opposed to like, I know this is a burden for me, just kind of acknowledging for them that, like, you're right, I don't know this, but I'm here for you, and help me understand how to help you. So I think kind of approaching it in that way sometimes can be less conflictual. I saw we had another chat too. Great questions. Was there another chat? Uh-oh, did I lose our screen?
It's from the reminder type app. So Med Action Plan, I think you can set that up. That's one that works. I like it because it works. The transplant center has an account for it that they can put the medications in, and it syncs to your adolescent app, and then they swipe whether they took it or not. And then I think you can set up that parent gets the notification, because I know our nurses can set it up that they get the notification if the patients are taking their medications or not. So yes, I think that there are some, whether or not adolescents want to sign up for an app that will alert you when they take their medications or not, that's a different kind of conversation. But yes, I think some of those things do exist.
Mango Health is another one that patients like. It's a free app that they tend to help. And I think Mango Health actually has, like, you can sign up for like a caregiver account, and it will automatically alert the caregiver that they went in and said, yes, I took the med. So that actually breaks down the need for them to let you know. Looks like we have a few more minutes. What other questions do you guys have? Hi, Kelly.
Hi, I was just saying that could help diminish the did you take your meds? Did you take your meds thing, right? Yeah.
Yeah.
You can.
Yeah.
And again, some of them you can put them in together. The My Med Schedule app has pictures of it, and so then if there's a dose change in the clinic, the nurses can push it right to the app, and it will update the app too, so that it reduces some of the user error and making sure you put in the right dose and timing of it as well. Mm-hmm. Yes, we tell teenagers, like, I know your goal is to get your parents off your back, but your parents' job is to be on your back about this. So it is kind of striking that balance of, if you show your parents you're doing this, they will ask you about it less. So kind of trying to find the right communication style.
Right.
Yeah, we'll usually do like a week trial period, and like, if it's not working, then we're gonna have to go back to the old way of doing things, because we can't mess around with rejection, and so usually we just try to be motivated by that piece of independence, with the goal of eventually being your parents. You don't have to text them at all, because you've now established that you can do this.
It seems like that would even be a good app to introduce. I mean, because let's face it, a 7-year-old's probably more apt at apps than we are. But even at school, because you're relying upon nurses at school to give the medications, and then the worry from a parent is you're letting your baby go and they're going to school, and are they getting their medicines on time? So starting them early with a watch or something to have an app. I don't think you can ever start too early with your kids to prepare them for independence. I mean, ultimately, we've done a good job. If, we as parents, you don't want to say, I'm going to cling on them forever and keep them forever, and that's my goal. You want to, like, get them out of the house. So starting early and having conversations with them, even if it's just to put that app, I like that idea, because I think that would help the anxiety even of the parent at an early age.
I always tell parents and caregivers, when we're talking about increasing the independence of your child or teen, the goal is that when your well-deserved trip to a deserted island is won, that you will be able to go, and your child will know when they're supposed to take their meds for that 1 week. It's not forever, but thinking about how to help them. And yes, absolutely, from an early age, we think that's very important, especially if they're interested and invested early on. Are there other questions or parts of the process, whether it's new diagnosis, waiting? I know a few of you are here in the kind of post-transplant adolescent phase. Are there others? Oh, we're getting an alert.
We're going to be transported, I think, in about 52 seconds.
Yeah, here we go.
Well, I'll just say from the North Star Reach team, for Coach and I, we get to know the kids at camp, but we don't know what, they're going through the rest of their lives. And this is just, it's going to be great to have this just to share with our staff, like to understand the complexities. So just thank you all for giving your time and Colleen and Deanna and just the group, kind of great questions. So thank you.
Well, thanks for having us.
Shelley as well. Yeah, thank you.
Yes, thank you.